Seeing and hearing no other questions, we will go next to Paul Kidwell, who, as I mentioned to him earlier, seems to somehow always end up at the tail end.
But I learn so much every time, so.
It's great to see you, Paul.
I appreciate being with all of you this afternoon. I had actually written this evening, but I got to scratch it out. So this afternoon. We've submitted testimony on a number of bills today, but I wanted to take my time on HB 5045 and 5049 and just highlighting some of the key points we make in each of those bills. Related to the CON process, as has been noted, 5045 proposes a fundamental restructuring of the CON process in our state. We certainly appreciate the intent of the administration to create a process that moves applications more expeditiously. There are a couple of provisions or lack of provisions in the legislation that I'd like to highlight. The first, and as Boyd Jackson from the Office of Health Strategy noted this morning, the bill allows, through the process, the unilateral imposition of conditions. Currently, in today's process, those are negotiated with OHS, and in this new process, those would be sort of take it or leave it conditions. We think the bill also needs to include prohibiting applicants from being mandated to meet requirements or obligations that are not set forth in statute or regulation in order to obtain a CON. We believe that those conditions should also be justified, and the duration of any condition should be justified by weighing the burden of the condition against the benefit. There's also some discussion related to the flipping of the hearing requirements. Not every CON application should be subject to a hearing. This change in process will significantly slow down CON approvals and subject the most administerial CON requests to an overly administrative process that is not required. There's also a significant shift in that CONs will be determined by a 3-member panel. We're concerned that the infrequency with which the panel will meet will mean CON applications are delayed and not determined timely. We also believe the legislation requires clarity related to the role of the panel. Will the panel preside over hearings, or will they convene to make determinations? If they're not presiding over the hearings, who will be conducting the required hearings? And will the panel be able to meet in between their scheduled quarterly meetings? We certainly appreciate that there's a change in service terminations where there's a requirement that the Department of Public Health Commissioner would have to approve a plan. What we're concerned about with that is there's no off-ramp should the DPH Commissioner never approve the plan for the service termination. There needs to be some due process where a applicant could appeal sort of a never-ending process with the department. Related to 5398, certainly there's been quite a bit of testimony related to that bill today. As we've noted in the past, we are concerned related to the review of transactions involving any healthcare entity, including that the Office of Healthcare Strategy or its successor organization would be able to participate in the AG's process, basically creating a separate CON process through the Attorney General's office. What has not been noted today is there's a separate section in the bill at the end related to a requirement that to include the corresponding actual cost of each related good or service when a hospital files its price master. I think the bill just generally doesn't recognize how hospitals do this process. We don't do it by service, we do it in the aggregate, and it's a means to understand how we're getting reimbursement from insurers. And the notion that we would have to do this by service would be extraordinarily administratively burdensome and expensive. Happy to continue to discuss that provision with the committee, and thank you.
Perfect.
Sorry, Kathleen, I talked right over you. I'm sorry.
The voice is back.
Thank you.
Oh my gosh, it's great to hear Kathleen's laugh. Paul, thank you for your testimony. Your testimony is online, correct?
It is, and it's much more extensive related to certainly the CON bill. We have some very specific provisions. I think just generally we'd like to engage in the conversation. We are glad that the administration has proposed something with this committee, and CHA certainly has been talking about the CON process for some time. We think there are things that should be corrected. We think the intent is to make CON more efficient and effective, but we think there are some things in here that won't get us to that end. And so we just want to keep talking about how do we improve it.
Thank you. Senator Almar? No, I'm good for now.
Thank you for your testimony, and I think this is a big shift that's happening from the Office of Health Strategies to the Department of Public Health. This would be a good opportunity to revamp some of the things. So agree with you about the process issues. Like I was having a conversation initially with Boyd Jackson, was that there's a part that is what condition situations should require. That's a separate conversation, and the part that I think many of us may agree with CHA is the process part, the streamlining part. I think there's an area of opportunity there to make it more efficient but fair at the same time, so that everybody has a say. But it needs to be efficient, and there should be pathways, and there is more than one pathway depending on which path it would be. And the area that perhaps I may disagree with CHA is that when somebody's going to leave a community, I would like to have a CON process there. Not necessarily as robust or challenging, but we need to have a frank conversation of who's leaving and why, and then what's going to be the negative impact.
Yeah, certainly, I think contemplated in the legislation is that a plan would have to be submitted to the Department of Public Health, and the applicant would have to explain why they were removing the service or ending the service, and what would be the steps to remediate any impact for the service. So certainly, Senator, happy to continue to talk to you about that, because certainly those decisions aren't made lightly.
Right. And so I saw that part, and to me it's good that that information will be there. The challenge I have is, I'll use a hypothetical example. So let's say Wyndham healthcare is being taken away. The women will not be able to get any OBGYN or women's healthcare issues. While the hospital may put that information to the Department of Public Health, I want the community to be able to come up and say, no, we need this help. There's going to be a big vacuum. There'll be a gap created. So it needs to be a public conversation around that, so that we can start to see what else can be done by the state. And if the hospital cannot do it, there may be ways around it for some support systems that can be created. Yeah. So that's where I think there's an area of opportunity. When you withdraw support or service from a community, we need to have that community be aware of what's going on. And on the entry point, I think that should be made easier. Exit should be a little difficult. Not extremely difficult, but difficult. And the process should be efficient. So that's the simplistic thing. So I think we will see eye to eye on a number of different aspects for sure. And then would love to coordinate collaboratively with everybody and getting everybody together to make the best decision.
Appreciate that. Thank you.
Good. Representative Claridge's teacher.
Thank you for being here today. I think there's something in this bill for everybody to hate.
Yeah.
And maybe more than one thing in the bill. I do think everybody is in agreement that we need to streamline whatever process we have, because it takes too long and there's too many obstacles to go through the CON process. So I'm hoping at the end of the day we have something that we don't hate. And that's a lot of times what legislation that comes out of here is a compromise, and we'll work with CHA to address some of your concerns, because I do think that if a hospital isn't making money or they can't get the help with the doctors, they can't keep a service if they can't keep the doctors in. So there's, I think that's worth a conversation to try and figure that out as well.
Appreciate that. Sometimes these CON applications are symptoms of other things, mm-hmm. right? And so we certainly try to keep that in mind. And we also now have experience with our sort of the expedited CON process related to bankruptcy, where we know that these processes can be done efficiently with due diligence, and sort of done in the best interest of the state. So we know we can do it. And now I think it's applying it to a broader set of CON circumstances.
Thank you. Representative Kristen McCarthy-Vahey has another question.
Thank you, Senator Amar. And so to that point, Paul, besides and outside of the expedited process, would you say that there's been a change and improvement in the time and experience? Like, I think we've heard from OHS that they have, shown us data, but just from your end.
Yeah, I think from our members objectively, there are certain CONs are moved more quickly than they had been in the past. So I think OHS had been making a concerted effort to try to process those things more quickly. As Boyd described this morning, there are structural things about the CON process that make it burdensome, make it expensive. If we could, in this legislation, amend those things that make the process burdensome and expensive while not foregoing the review that we all think should be done, I think we'd be in a better position. I think the other, beyond structure, we've talked about this with this committee, we're concerned about a CON process that is used to extend other health policy ambitions of whatever administration is in power at the time. That the CON process is not a policy-making apparatus, it's a health structure apparatus and what we want healthcare to look like in Connecticut.
So thank you for that answer. And something you said, you used the word burdensome, but I think referencing Mr. Jackson's testimony, there are also statutory timelines that are in place, right? Like, is that part of what you're talking about with burdensome? I'm just going to give words to what I see you saying.
Yeah, I think that
like
the time frames also can be. I'll use an example. So I worked at the Center for Medicare and Medicaid Services in Medicaid for many years, and there are statutory time frames in the Social Security Act about how states and the CMS interact, but they get used to say, let's pause this and ask for more information, and then we'll come back and let's ask for some more information over here just to buy time. And so the corollary in Connecticut is that the statute can be used to buy more time, ask more questions. And all of that means more cost and more delay. And to what end? At the end of the day, are we coming up with the same answer that we would have come up with 90 days prior? And did all that information we provide actually get used in the process or not? That's very opaque today.
Thank you. That's actually, it's helpful. I would say what I'm hearing you say, and you can correct me if I'm wrong, is that there definitely has been improvement, especially in certain areas, that there is a need to make changes to the statute so that we can continue to improve and try and get closer to what the expedited process has looked like and continue to review. So you're not saying, and you haven't said consistently over time, we want to get rid of this process. We just want to make it work better for everyone and in the end for the patients who are receiving care.
Absolutely. We do not want to get rid of the process. We think there's room for it, but we think it needs to be improved, and unequivocally it needs to be improved.
I can almost promise we'll have a lot more conversations before the end of the session.
I hope so.
Yes.
I actually hope so.
It's much needed. Thank you so much. Thank you for being here with us all day.
Thank you.